Assalamu alaikum wa rahmatullah. Welcome everyone to our webinar regarding your diet health research. My name is Rani Monteri and I will be your lecturer for this course. So for our first topic, it will be an introduction to research and its processes regarding the main points in any health or clinical research. First of all, the definition of research is the investigation that is undertaken in order to discover any new facts or even get additional information regarding a specific problem. And scientifically, it is defined as the systematic collection, analysis, and the interpretation of data to answer certain questions or even solve a problem. So there are criteria which the research process should always meet. These should include its objectivity of the research, meaning that the research is not personal affair, but should be free from any personal interpretation or bias. And the variability, it should be clear on how the investigation was carried out and how the result and conclusion were arrived at. And thirdly is the openness and the accessibility of the research method that is used and also the knowledge that was acquired, which are necessary to be able to meet the previous points. So in any research process, we should meet these three criteria in order to conduct a scientifically appropriate medical research. In addition to this, any research should be defined by certain characteristics, including a clear statement of the problem, requiring a clear plan also, and it should build upon existing data and collect new data which are required to answer the certain problem. So there are different types of research. These can be a fundamental, pure, explanatory, or basic research, or it can be practical, such as clinical trials, which is applied, policy-oriented, or action-oriented research. So in the first type, it generates new knowledge and technologies to deal with major unsolved problems. In regard, there are no previous data regarding this issue, therefore, we should firstly conduct the fundamental research. Where in the second type, it starts with a practical problem or a question with the result of the research being capable of immediate use. So much of the applied research can use theories which have been derived as a result of fundamental research to solve the problem. So we can never conduct a clinical trial immediately before we have conducted basic research about the same issue first. And the importance of any nutrition research in the medical field, as it can expand the knowledge of the insight into nutrition problems and also the actions that are the researcher required to contribute to the quality of direct nutrition care and help to determine the methodological action which help in providing scientific-based justification. Also, it has a function related to the quality assurance and the maintenance of the high professional standards, and it can contribute to the expansion of the nutrition knowledge and the professional practice. So what are the characteristics of any successful research? First of all is the activity and the involvement, which can be good and frequent contact both out and in the field with colleagues and patients. Also, it shouldn't be with any expedience as not undertaking because it is easy, cheap, quick, or convenient, but rather to answer a real problem to help in the medical society. Also, intuition, as feeling that the work is important or that it meets certain criteria, and the theory which concerns for theoretical understanding of the issue and a real world value. Any research must have a real impact on patient life, therefore problem arising from the field and leading to useful ideas. So the research problem, which is a research project that starts off with a problem or a question. Therefore, a problem is defined as discrepancy between what should be and what is existing. And a well-defined problem can lead to good statement of research questions, hypotheses, and also methodology. So the criteria for the researchable problems include a discrepancy exists between what is and what should be, the question about what is the discrepancy that exists, and there are more than one possible answer to that question in a certain point, and it can be answered within a reasonable time scale and cost. Also, that the problem should be made measurable, therefore, we can actually see an impact or detect a difference. So which problem we should give the priority first in order to investigate? This should be relevant to the practice we are in or the patient major issues that we are in, and it should avoid the repetition. It should be feasible in terms of time and cost. It should be politically accepted and applicable in that recommendations could be stated from it. And it can also be an urgent problem or also ethically acceptable, which could not be acceptable but accepted with minor ethical problems, or either not ethically accepted at all. So it will depend on the problem we are having and what we want to achieve by conducting the research and the impact we want to make. So to analyze any problem in a research, this should focus on two issues. First, identifying the factors that may have contributed to the problem, which are the contributing factors, and these factors can be grouped into three main categories. These can include socio-cultural issues such as age, education, social class, belief, and etc. Or it can be service related, such as relating to the facilities, the available resources, or even it can be disease related, such as coronary heart disease, DM, or etc. Also, the focus of the problem should be on stating the association between each factor and the problem in mind. So, to analyze any problem, we need to draw a diagram and state the problem in the middle with any possible contributing factor that can lead to this problem. So, in defining the problem, certain issues should be considered, such as the incidence, which is the observation of an event that is usually the first clinical sign of a disease. Also, the prevalence, which is recording of the presence or even the absence of a disease at a point in time, and the geographical areas that are affected, the characteristic of the population group, the probable reason for the problem, and any possible solution or unanswered questions. So after defining the problem that we need to do the research about, we will then decide the research title. So as we said, after the problem is defined and all points are taken into consideration, the research title should be clear and could be formulated but it should never exceed 2 lines. So it should include the following point: the population, for example, males or female, adults or children, or even pregnant women. So defining the population in the title is necessary. Then the area in which we are studying these sample of patients, such as hospital, city, a village, or etc. In addition to this, the time scale, such as the year or the month. And in other words, it should be aim specific, place specific, and time specific. So after identifying the problem and choosing the title, we should conduct a literature review. So why do we review the available literature? This can help in supporting the argument for need of the research. In other words, to give the reason why the topic is of sufficient importance for it to be researched, and to provide the reader with a brief, up-to-date account and discussion on the issues that are relevant to the topic. Also, to discuss the relevant research that is carried out on the same topic or even a similar topic, and to prevent the repetition and duplication of doing research that has already been carried out in the field. This can also help to support or even define the statement of the problem. It can also help to determine a suitable type of methodology or outline the problem or topic and the need for research in this practical area, and using appropriate recent literature review about other work in the field. In addition to this, starting in a systematic way by defining the topic, the causes, the studies, and why there is a need in this topic exactly, can help in the source that is referred or should be relevant to the problem, and it should include a range of written sources such as article or research thesis with studies that are included that should be on one actually read of the researcher with honesty. So from where can we obtain this literature review? The sources of information can be numerous, but it can include the community, the district, or provenance level, such as clinic, hospitals, opinion, belief, or local surveys. Or it can be obtained from a national level, such as articles from national books, previous researchers in the university library, for example, Ministry of Health, and etc. Or it can be obtained from an international level, such as information from the WHO, from the internet. So, in other words, the source of information could be from individual groups or organizations, and information could be from a published source, such as books or articles, or it can be from an unpublished information, such as report, previous unpublished thesis, for example, and whatever we believe is to be a source of good information. So how can we write a source? For example, for books, if we are using Vancouver style, which is one of the most common referencing style, we should start by stating the surname, which is the last name, followed by the initials, the title of the book, and the edition place or the publisher with the year of publication. And this is an example of how to reference a book in Vancouver style. There is also one other common referencing style, which is Harvard style. It includes the surname followed by the initials, the title of the book, and the publisher or the page number if particular. So these can be similar in somewhat, but when citing the reference in the article itself, it can be different by either stating a numerical reference or a last name and year of publication reference. These are also other examples of how to reference a journal article in Harvard style, which is similar to referencing a book in Harvard style. The only different thing upon citing with either of the most two common forms, the Vancouver and the Harvard, is when we cite an article from a web page or from the internet, we need to include the URL of that page and the date in which we accessed that information. So after we have done our literature review, we should then start by writing our research objectives. So an objective summarizes what is to be achieved by the study if it answers the main questions on what, where, and why, and also the specifying the question to be answered and help to focus the study with avoiding the collection of any unnecessary data and organizing the study in a defined part or phrases. So when writing the criteria for research objective, it should be written in the SMART abbreviation or method, which include a specific, measurable, achievable, realistic, and timely objective. So a specific objective means to make the study more focused. Measurable objective is possible to be measured with sufficient accuracy. Achievable, it can be done, meaning, and realistic or relevant, this is in relation to cost-wise, and timely within a reasonable time scale that this research can be achievable. So the types of objectives can be general objective, which is the principal objective that must be stated, and questions that have already been asked, and answers which are clear from the literature that should be avoided. So it is usually obtained from the title of the research, and they are usually written in general terms, but they should be realistic and should be clearly stated. Also, they should cover the problem and factors or even the variables under the current study. In regard to the specific objective, it is the breakdown of the general objectives into a smaller logical part, since it is impossible to use a single question to answer the problem. Also, each objective needs to be assessed by the collection method tools. And when writing these objectives, we should start with the word to, for example, to identify, to assess, to measure, to evaluate, as these could be measured. Therefore, we should start them with the word to. We should also avoid terms such as to know, to understand, to see, since these cannot be measured, therefore they wouldn't be regarded as appropriate objective. Also, they should be related to the title of the study which we are studying. And after stating our research objective, we will then start with writing our research hypothesis. So a researcher conducting a study usually has a theory in mind. And this hypothesis is a research question which fit into a particular program of testing. So it is a statement which predicts the occurrence in a certain condition based upon the theoretical considerations. And there is the null hypothesis, which is the hypothesis that nothing would change if these results were untrue. And there is the alternative statement, which is impossible to prove that all hypotheses in one study to be tested, therefore it cannot be achieved within one study. So there are 4 conditions that should be met by the hypothesis. It should be logically consistent. It must not predict the results which are inherently contraindicated. And this hypothesis should be stated as simply as possible. And the predictions from the hypothesis must be verifiable, as if they are not, then the hypothesis cannot be tested. Also, the hypothesis must relate to a matter in which it can be clearly defined as the terms of factors that are associated with the problem. After stating our hypothesis and objective, we will then start with deciding or writing the research methodology. So the variables, which is the quality, the characteristic, or even the constituent of an individual, which is changeable and measurable. As such, it can take different values. So there are different types of variables. These will be dependent variables, such as the variables that are used to describe or even measure the problem under study. For example, serum cholesterol level in the study of chronic heart disease risk factor. So our variable will depend upon the study in mind or the study question. There is also the independent variables, which are the ones that are used to describe or to measure the factors that are assumed to cause or even to influence the problem, such as the intake of short-chain fatty acids in the study of coronary heart disease. There is also the confounding variables, which are associated with the problem or the outcome and with a possible cause of the problem as the exposure, as it can also strengthen or even weaken the relationship between the outcome and the exposure. An example of this is in a study to determine the effect, for example, of fruit and vegetable consumption on chronic heart disease. Smoking is considered as an independent variable if it is associated with the outcome and only not with the exposure, which is the fruit and vegetable intake. However, it is a confounder if people who smoke buy less fruit and vegetables, and smoking can increase the risk of chronic heart disease. So, this is an example of a confounding variable which can affect both the outcome or the problem and also the suspected effect on the problem. There is also the background variables, which include the demographic characteristic, such as age, gender, educational level, socioeconomic status, as well as information such as tribe, religion, and employment status. So the variables can be one of either two, a qualitative or categorical, or a quantitative or a numerical variables. So this will depend upon the type of the data that we are collecting and also upon will affect our methodology and our research design in general. So the qualitative variables are those variables which cannot be measured in figures as they are either nominal or ordinal data. And the nominal variables are defined as variable which one can name individually, and they are not measured but simply counted. They often consist of unordered either or type observations, and in this case, they are called binary variables. So the nominal variables can also be referred to as binary variables. An example of this is, for example, dead or alive, male or female, pregnant or not pregnant. And they can also have more than two categories, and in this case, it is referred to as non-numerical data, such as blood group, either AB, or O in general, or even it can be the country of origin, social class, race, etc. And the qualitative variables can also be ordinal or ordered or even ranked as they may be put in order of increasing or decreasing the quantity or improvement. And an example of this is after treatment, a person may be either improved the same condition or worse. Where in the quantitative, the numerical variables, these are the measured as quantities and therefore can be referred to by a specified number. So they can be numerical districts, such as data consisting of counts without fractions, such as number of previous babies who are born to, for example, 100 women, the number of deaths in hospital. And they can also be numerical continuous, such as data that are measured, which can take any value with a given range. And they can have fractions such as maternal age, birth weight, blood pressure measurement over a specified period. So any data that can change over time. And the continuous variables could be converted into nominal variable. For example, diastolic blood pressure, which is continuous, can be converted into hypertension more than 90 and normotensive less than 90, which sometimes can make the data either to summarize or even to make it more simple to analyze. So this, of course, will depend upon the type of study that we are conducting and the result that we are looking for. So the operationalization of variables with some variables that are directly measured, such as sex, weight, height, and others that need to be operationalized, which mean that making the variables measurable, for example, the social class using positions which are not measurable, but those who are scoring, for example, 0 are defined as very poor condition, 1 to 2 poor condition, or even more than 5, for example, the patient has recovered. So it will, of course, depend upon the data we are needing or even the study objective. So in general, data are observations that are made on an individual consisting study sample, where quantitative data are the data that are based on numbers such as age in years, where the qualitative data are the ones that are not based on number, but rather on categorical scales such as gender and social class. And the parameters are defined as quantities that are used to describe the characteristic of such populations, including blood pressure of middle-aged men, and the validity, which is concerned with whether the instrument is actually measuring what its purpose of the measurement is. And for example, a study that is considered to be valid if the finding can be taken as being a reasonable representation of the sample in which we are studying the problem. Also, the internal validity is one that is relating to the information obtained from the subject in the study in terms of being valid, where the external validity or generalizability is one that relates to how the information obtained can relate to the people outside of the study sample. So this relates to the representations of the study sample in which we have assessed the problem. And the reproducibility or repeatability is concerned with whether the instrument will produce the same result when it is administered repeatedly to an individual in the same circumstances. And the variability is the quality, the characteristic, or the constituent of an individual, which is changeable and measurable, and as such can take any different values. And the attribute is a qualitative variable that is not changeable for the same individual. Where morbidity is defined as any departure from a state of psychological or psychological well-being with mortality or even death. And the exposure is defined or describing the factor as variables or measures to which a person or group of people come into contact with, such, for example, as smoking. And outcome is defined as describing the factors which are being studied in relation to the effect of an exposure, and they are often disease state, anthropometric, or psychological measures, depending, of course, on the issue in mind. So the study design is another important consideration when starting any clinical research and deciding which design is the best to answer the problem we have. So according to the kind of the problem, the information already available when we conducted our systematic review, and the resources that are available, then the study type is selected. So a major determinant of the study design is the problem we want to assess, and also which type of facilities that we have which can help to answer this problem. For example, we cannot start by conducting a clinical trial when we don't have the required facilities or resources to start this type of study, but rather we may have the support or the resources to conduct a quantitative or a research focused with questionnaire type of studies. So there are two types of studies that exist. This can be either observational or experimental studies. The observational studies or the non-intervention studies can be divided into further types, such as cohort studies, which are follow-up longitudinal studies. It can be cross-sectional studies, including surveys, descriptive studies, or prevalence studies, or it can be a case control study with a case referent or a retrospective study. The second type, which is the experimental interventional studies, can be either community trials or community intervention, depending, of course, on the problem that we want to answer. So in the observational studies, the most common type is cohort studies. And a cohort is used to describe those who are born during a particular year and then followed for a period of time. It could also be used to describe any group of persons who are followed over a period of time. And a cohort studies could be a prospective study in which a defined population can be identified who have been exposed or will be exposed to a factor which can influence the probability of occurrence of a given disease or any other outcome. So cohort studies observe the progress of an individual over time, and they can study the proceeds from the causes to the effect, and they can also help to determine any causal relationship between two or more variables. So the interpretation of these studies is often much more difficult, and the design of these studies should be very careful to prevent the occurrence of any missing data or bias, and it can demand time and resources of the investigator. So these can include long follow-up periods, such as the mortality within sample, which can be a problem, the non-availability through geographical moves, or even unwillingness to continue the cooperation with the study. Also, a study may follow up two groups of subjects, one exposed to a risk factor and the other not, to see if this exposure can influence the occurrence of the disease, such as cancer, for example. And these results are represented such as the incident rate, the relative risk incident of a disease, and etc. So the other type of cohort studies is the retrospective studies, in which a group of subjects are identified in the past and then followed up from them. An example of this is all low birth weight babies who are born in a maternity hospital 60 years ago are being identified and used as a sample in a cohort study. So overall, cohort studies require larger sample size and probably long follow-up periods. The second type of observational studies is the cross-sectional studies. They are the simplest form of epidemiological studies, and they investigate the relationship at a single point in time, and they are unable to provide evidence of any causality for this future retrospective or prospective or even experimental studies, which are required to test whether the relationship are causal or an exact or true effect and impact. So in cross-sectional studies, there are three general forms of relationships that can be looked in for the cross-sectional studies. This can include the difference between groups in the level of some variable, a difference between group in the rate of a condition occurrence, for example, or an association correlation between two variables in the sample in general. Also, it could be used to identify how many people in a given population can possess a particular disease, opinion, or whatever, and as such are known as descriptive studies. And these descriptive studies involve the systematic collection and presentation of these data. So they can also be used to explore the aspect of a situation or seek explanation, as well as provide data for testing a hypothesis. It is very important to choose a representative, non-biased sample, and they need a large sample size, a description of time, place, and people in order to be implemented appropriately. So, in order to investigate the causality in epidemiological studies, it is important to include elements relating to cause and the effect. Also, it is considered as cheap and work backwards in time from the effect to the cause, and they can start with identification of persons with the disease or the outcome variables of interest in this particular study and a suitable control reference group of people without the disease. So, the cases with the disease that are identified, the effect and controls are obtained to compare them, and these exposures of the case and controls to the factor under study, the cause, are then compared, and if the exposure are sufficiently different, then this supports the cases for the causal link. Also, the control subject can be chosen to match the individual cases for certain importance of variables such as age and sex, leading to what is known as a match design. In terms for the comment from Aquila, I am actually explaining. It's just that I'm writing what I'm explaining to be as a reference for you rather than just mentioning bullet point or head points. يعني أنا كاتبت لكم الشرح بالكامل عشان إيش يكون عندكم كمرجع وليس قراءة. هي النقطة إنه أنا كاتبت لكم كل شيء مشروح. Please focus because we will be having a discussion at the end of the course. And I will be sending you these reference PDF for the persons who were asking. So, as we were saying, the case control studies, the cases with the disease that are identified and the controls are obtained to compare them. So the controls can be sampled from a suitable non-diseased population, leading to an unmatched design. And it is not correct to require that the control groups be alike in every respect to the case, as this would be impossible to achieve because there must be some variations in the sample. And the major difficulties in such studies is the selection of a suitable control group. For example, we needed to be representative in terms of the age and gender, the disease status, but we cannot control for all confounding variables. So they are usually easy to carry out compared to other type of studies, and rapid or inexpensive, and it can require few subjects, no risk to subject, and the risk factors can be identified, but it shouldn't require any follow-up of the individuals, or else it would be classified as a cohort study. It should allow the study of several different risk factors suitable to investigate the rare disease, and they can yield quick results and cannot provide information about disease and other than those that were selected for the study. But it can, of course, faces some problems such as bias or ethical problems if this wasn't conducted to the fullest appropriate. And also, in some cases, this type of study is not suitable for the evaluation of therapy, and cases and control cannot be representative for the whole population in general. So, choosing the representative control group is of major importance in this type of studies, as it is the most important point for it to be representative of the general population. So after discussing the observational studies and their different design, we will now continue with discussing the other type of medical research, which is the experimental studies. So the basis of all experimental studies is that the effect of any treatment on an outcome must be compared with the effect of a controlled treatment on an outcome. So it is not ethical to do experimental studies where the exposure is still unknown to be harmful, and as such, the non-experimental approach is used with uncontrolled studies of any designs that are very difficult to interpret. So they are set out to alter rather than to observe the exposure, and they should be clearly defined the aim, which is essential in conducting any experimental study, meaning that the aim or the purpose of this study outweighs any possible risk factors. So experimental studies are assigned to subject by the investigators, and it can have strong evidence for the effect of an exposure or outcome. And they can also measure the exposure in the present or modify the exposure. and it can be conducted among individuals to assess the change or among even groups, for example, the community, to detect any large variabilities of outcome. So they can also range from the very tightly controlled laboratory experiment to large-scale community intervention programs. So the size of the experimental study will, of course, depend upon the problem that we want to investigate. So some of the common terms that are used or terminologies used in experimental study include the community trials or field trials, such as, for example, mass education campaigns that are aimed to change people's knowledge and attitude toward, for example, smoking. Or it can be the community interventions in which the exposure is usually given to subjects, such as in the form of supplement injections to control access to exposure, for example, vitamin A capsules, and etc. So in both of these types, the community trials or intervention studies, the exposure and the outcome are measured at least at a less controlled condition, and it can answer the question, does the treatment work in practice under day-to-day conditions, which can apply in the real world? And the major objective in this type of studies is to assess factors which affect the implementation of the intervention. And they are also considered population-based studies because it will include a large number of participants if this was a community trial. So the third type, which is the clinical trials, these are individual-based, used when the subject has defined clinical status that may have any additional exclusion criteria. And they are usually conducted to measure the effectiveness or measure the exposure and outcome under a controlled condition. And it should answer the question, does the treatment work in theory without consideration of the practical constraints or imposed in the real world? Also, major objectives is to explore the causal mechanism between any two effects in mind that we need to assess. So there are general consideration in experimental studies as including the selection of the study population, which is of most important to carry out a representative or of a value impact on this population in specific. So when we select it, if the problem, if they are lost to follow up and as such will affect the sample size. Therefore, when we select the study population for this type of studies, we should increase the number over the sample size of the power calculation in order to account for any dropout or withdrawal from the study. So the allocation of treatment program should also be random in each group, and we will be discussing the allocation of treatment or intervention among different groups. Also, the length of observation, that could be minutes, week, months, or years, will all depend upon the sample size that we will need for the study. Also, we need to consider the observer effect, and ideally, it should be blinded to the groups and the researcher who are conducting the study in particular, and the participant effect. And it should be also blinded to the true nature of the study group and analyzing with the interpretation with outcomes that need to be measured at baseline and also after the treatment to assess for change. So an important consideration in any types of study is the study population. So the population must be clearly defined, and this will help to achieve the study aims by controlling for exposure. So this is true for the selection of population with the characteristic different from the general population in one or even more aspect of lifestyle, such as vegetarians, or even having a unique history, for example, female who were born during famine or who had low birth weight infants. Also, they need to be identified by their place of residence area or their occupation, for example, their job, and their personal characteristics such as in-hospital patient, female, gender, and their age. So when we are choosing the study population, it is important that the result be extended to the whole population of which the study sample was drawn from. And the more clearly the population is defined at the beginning of the study, the easier the recruitment will be, the data collection, analysis, and writing up. So if we started our research process correctly and thought it carefully from the beginning, we will end up with having a better result and better impact on the medical research field. Also, the targeted population, once it is defined, they are usually too large to investigate. Therefore, we should start by collecting or conducting our sample size calculation. So to produce a workable number of subjects, some form of sampling procedure is needed. And sampling is defined as the selection of a number of study units from a defined study population. So the correct way to avoid the selection bias is to make use of randomization process. And also sample is taken from the study population to provide an estimate of the population parameters, and it is normal practice to make the sample representative of the population from which it was drawn. Where sampling unit is defined as the items that are to be sampled, and they are usually the subject, but they can also be clinics in a town or schools in a country. Also, the sampling frame is defined as a real or imaginary list of the sampling units that are illegal to be sampled. Where the sample size is the number of the individuals in the sample, and the sampling fraction is the fraction of the population size taken as the sample. So this can be calculated as the sample size uh, divided by the population size, where the sampling interval is defined as the interval between two consecutive members of a sample in a sampling frame. And the sampling variation is defined as the fact that the different samples have different results, for example, between subject variation and also within subject variation. And in regard to sampling, as for the selection of a number of study units, we need to ask three main questions. The first is, what is the group of people from which we want to draw a sample, the study population? First, we define the study population. Then we ask how many people do we need in our sample, which is the sample size, and this will depend, of course, upon certain calculation that we will be discussing further on how to calculate the sample size. Also, we need to ask how will these people be selected, which is the sampling method that we will be using. So a representative sample has all the important characteristics of the population from which it is drawn. So this shouldn't be true for all variables, but the most important variables that we are assessing. So the sampling method and procedures are divided into two main categories. The first is the probability sampling method, which involves a random selection procedure to ensure that each unit of the sample is chosen on a basis of a chance rather than specified collection. So in the simple random sampling, it involves the selection of a random form of a list of a population, which is the sampling frame of the required number of persons for the study. And if it was properly conducted, this will give each person an equal chance of being included in that sample. So all units must be listed in numbers, such as the pre-existing sampling frame, and we should use of a sampling fraction, which is 1 in 10, or a fraction of 0.1. Where in the systematic sampling, this is a version of simple random sampling, which help in avoiding the need for a sampling frame from the beginning. So it involves choosing a starting point in the sampling frame at random, and then choosing every ninth person, for example. So it ensures that everyone has an equal chance of being selected. For example, if a sample was of 2,000 individuals and the sample was supposed to be 50, then every 40th person is chosen, and there would be a random selection of the number between 1 to 40 to start off the sequence. Therefore, this actually will be the first subject in a random selection. So choosing the selection method or the sampling technique will of course depend upon the sample size and the population in which we are conducted. So in another method of sampling, which is the stratified sampling, it involves dividing the population into a number of group strata where the members of the group share a particular characteristic. Then there is a random sampling within this strata. So one can use a simple and systematic sampling to ensure the desired representativeness of a specific subgroup. And in theory, stratified sampling can be more efficient than the simple random sampling techniques. So the number of the groups selected for the sample can reflect the relative numbers in the population as a whole. And if there is an equal number of, for example, male and females in the population, then there should be an equal number of males and females in the sample we are studying. So as we said, it should be representative. While another method is the cluster sampling, which involves dividing the population into a group of units or clusters, each of which contain individuals having a range of characteristics. So the subpopulation within the cluster is then chosen, and all units within each cluster are then sampled. So the clusters are selected using a simple or systematic or stratified sampling technique, and they are often, for example, geographical units such as village, clinics, etc. And this way is particularly useful when the population is large and require a great deal of effort and travel to get the survey of information. Where in the multi-stage sampling, this is an extension of cluster sampling, and it involves selection of the sample in stages, such as taking the sample from a sample, and it works from the larger to the smaller sampling frames, in addition to the units that are at one level, providing the sampling frame for the next level. And an example of this is the states that are selected in the first stage, the provenance, for example, in the second, and the area in the third. So, of course, all of this will depend on the problem that we are seeking to answer. Also, there is the non-probability sampling method, which is any sampling plan where it is not possible to include people by chance. And they are less complicated and are acceptable when there is no intention or need to make any statistical generalization to any populations beyond the sampled survey. Where in the quota sampling, in this strategy is to obtain the representativeness of the various elements of a population, and usually in the relative proportions in which they occur in a population. And it can help in ensuring that the sample is in a way representative of the general population, for example, in terms of age, sex, and social class. For example, men aged 40 to 50 with the history of hypertension. So anyone who meets these criteria can be included in the sample. Another example is if home visits are involved, then avoiding houses with the large dogs or with out order area and etc. And in the convenience accidental sampling method, it is sometimes used as a cheap way and doesn't produce representativeness of the finding. It also involves choosing the nearest and most convenient person that happened to be available at the time of the data collection. So the process is continued until the required sample has been reached. Where for the sample size, it is defined as the size of the sample that depends upon the degree of accuracy which is required. The greater the need for accuracy, then the greater the sample size will be. Also, the number of variables that are involved in the research, in which the more variables involved, then the larger is the sample size. Also, in type 1 error, which is when the rejection of the null hypothesis, when it is actually true, is referred to as a sampling type 2 error. So it is not the rejection of the null hypothesis, which is in fact false, but the probability of making this error. And the power of any study is the probability of accepting the alternative hypothesis when it is actually true. So significant usually mean of importance, and in statistics, the significance is the degree to which the obtained result or value didn't occur by chance, but can also be attributed to a specific cause or influence. And a significant test is used to decide whether or not there is a difference between the groups, and is usually set at less than 5% or 0.05, and it is decided before the study is conducted and known as the p-value. And the less the p-value is, then the higher the power of the study will be. إن شاء الله بريك الصلاة على الساعة 6. عذرا بس لأنه يعني من جميع أنحاء المملكة حاولنا نختار الوقت اللي يكون في المنتصف. So, with our second topic for today is the research ethics and integrity. So, in particular, in any research project, there must be ethics that govern the research process in general. And in clinical trials, these ethical constriction can be higher due to the involvement of human subjects. So in terms of authors, the name of them should be stated at the end of each statement, even if it was verbal or personal communication. So anyone who contributed to the study in the content of the study must be mentioned as an author of the study. And if this contribution wasn't significant, then they can be mentioned in the acknowledgement section. So reviewing the studies which stand with or against the study problem and not only with one of them is important, as this will avoid any bias, which is the deviation of the result or the influencer from the truth or the processes that are leading to such deviation. So bias is also any trend in the collection, interpretation, or even review of the data that can lead to conclusions that are systematically different from the truth. So bias can occur at any stage of the research conduction. So bias is also the distortion of the available information in such a way that it reflects the opinions or conclusions that doesn't represent the real situation. And people should consider the first ethical permission before carrying out any research that is usually obtained from the local area in which the study will be carried out, such as the hospital, the locality, the ministry, or the university. So there is also consent form in which the population under study can sign or give verbal approval to, which can agree to take part in the study, and they have the right to withdraw from the study at any time without any force, and that information provided by them will be treated with privacy and confidentiality to ensure that the patient feel free upon enrolling in this type of study. So why do we need ethics in research? The historic events and trials conducted which led to harm have shaped the regulations of research involving human subjects and also led to the introduction of the good clinical practice regulation and governance procedures for research. So any guideline that we need to follow now in research in terms of ethical points were developed based on previous event that has occurred in medical research. The first case was the elixir sulfonamide disaster in the USA's in the 1930s, with improper prepared medicine that led to mass poisoning and responded in the FDA response with the Cosmetic Act that created to ensure the drug safety tested before marketing. So the poisoning of all of the study participants has led to the development of the FDA regulation for clinical trials. And in World War II and the Nuremberg trial, this led to the creation of the Declaration of Helsinki in the 1950s and the foundation of the ethical principles in which the GCP was built upon. So after that came the syphilis experiment, in which the US public health study conducted for 40 years with the progression of syphilis that led to changes in the law of governing and protecting the participant in a clinical trial. And afterward came the thalidomide trial in the 60s, which led to changing in the legalization of the worldwide to ensure a strict testing of drug before it is being utilized. So with every adverse event in clinical trial came a new regulation that helped in maintaining the safety of the patients who are participating in the study. So this is the historical content in which the current good clinical practice for medical research is based upon. And as you can see, the latest incident was in 2005 with the research governance framework being developed. So in the Nuremberg Court in the 1950s, the principle of the conducted of all scientific research was based upon this trial. This included the voluntary consent, which must be obtained from all participants, and resulted for the good of the society with uncurable by other means, meaning that the problem that we are seeking to answer cannot be answered without conducting a clinical trial. Also, it should be built upon existing research if able. As we have mentioned previously, we will start with the fundamental research, then with the clinical research. And it should also avoid unnecessary physical harm and suffering on the patient. Interest of the subject should always prevail over those of the science and the society. So we cannot harm the participant and justify that by the bigger benefit or impact on the population. Also, protecting the participant is of paramount, and they should always be the first consideration rather than reaching a desired effect or result on the research. Also, it should be conducted by scientifically qualified persons, and the subject should be free to withdraw at any moment, and it may be terminated by the physician at any given point when seen that there is a negative impact according to the participants. So the good clinical practice is an international ethical and scientific quality standard for the design, the conduct, the recording, reporting of the trial, which involve the participation of human subjects. The GCP consists of 13 principles with the purpose to achieve ensuring the protection of the rights and well-being of the research participant, ensuring that the results of the research are accurate and credible. And this GCP have the origin of the Declaration of Helsinki that we mentioned and apply to all types of medical research, not just the clinical trial or the medicinal products. So it governs all types of medical research, not just the clinical trials. So what is the research governance or the ethical governance of research? So it is essentially a term covering the principles and the processes by which the standards are set in research. And according to the Department of Health, the research governance improves the research safeguard of the public by enhancing the ethical awareness and scientific quality, promoting the good practice, reducing the adverse incident, and ensuring lessons are learned, and forestalling the poor performance and misconduct. Also, it is for all managers and staff and all professionals who are working in the health and social care research environment, who are in charge of designing the research, participating, hosting the research, funding, or even managing and undertaking the research. So it governs all participants or all personnel who are involved in the research and every step of the research process. So who does the GCP affect? It affects those who are participating in the research in the health and social care setting, those who are hosting the research, funding the research, and managing or actually doing the research. And the main purpose for the ethical review of research is the protection of the rights, the safety, and well-being of the research participant. So the participant is at all time the most important thing to consider or person to consider in the research process. So the ethical principles of research are the four core principles, which are the beneficence, the non-maleficence, the justice, and the autonomy. And these four principles, which is the principle of the respect of individual autonomy, the individuals must respect as an independent moral agent with the right to choose how to live their own lives. While the second ethical principle is the principle of beneficence, which is that one should strive to do good where possible without harming the patient. And the third principle is the non-maleficence, which is that one should avoid doing harm to others, including the study participant. And the fourth is the principle of justice, where people should be treated fairly, even though that this doesn't necessarily equate to treating everyone equally. So all of these four ethical principles apply in conducting any type of research and was drawn about when writing the good clinical practice for the ethical consideration in medical research. So according to the Bichamp researchers, they stated that they don't rank these principles in a priority order, but many can argue that autonomy can be the dominant principle. And it is important to remember that not everyone can agree with these principles, and many can argue that they act simply as a checklist to cut the really assessing of the mortality issues, but they have become the key concept that the health organizations and the good clinical practice obtain the basis from for conducting any health research. So, in addition to the four principles that we have just mentioned, the beneficence, the non-maleficence, respect for autonomy, and justice, these should also include obtaining an informed consent from all study participants, the honesty and integrity of the research in general, and the confidentiality or anonymity of the information that was collected in the applied research, in addition to valuing the diversity within the society, and this can be obtained or conducted upon the sampling method that we discussed previously, and the scientific validity with the avoidance of any bias, which is a major ethical problem, and the competency of the research, which will, of course, depend upon the design of the method of the study. So for the first ethical consideration, which is beneficence, it is defined as the active promotion of the welfare of others, which is doing good for others. And to do good for others or the study participant or the community in general, this can be defined as improving the diagnostic, the therapeutic, or the prophylactic procedures for patients, promoting understanding of the etiology and the pathogenesis of a disease, therefore conducting a research to understand a certain problem. And it can include actions such as protecting the rights of others, patient or study participant, preventing harm to others, and helping those with disability or aiming to improve their quality of life or improving their medical condition, and rescuing those who are in danger by trying to find new treatment options. So, in the hospital setting, this can frequently clash with respect for autonomy, which is the Britannia's heritage of the doctors know best for the patient outcome. So, this can include benefit for the patient, for the participants, or other patients with the same condition, benefit for the medical staff or the health organization, benefit for the researcher themselves, which is deemed insufficient justification in most of the cases, and also benefit for the general society by improving our understanding of certain disease. For the second ethical consideration, which is the non-maleficence, this is essentially the requirement to do no harm to the participant, but it is not the same as being wrong. So this would include do not kill, do not cause injury or pain or suffering to the participant, do not incapacitate, or do not cause offense to the participations. It can also be used to support issues of confidentialities, such as the obtained data from the participant in the study. But also, we should think of the hospital setting as there are many activities which can contradict this stance. And some of these can overlap with the beneficence, which we just discussed. And therefore, this good clinical practice for ethics review was only took the important consideration from each of these points or these philosophical inputs. So, what is harm? Harm can be subdivided or categorized into different categories. The first is the physical harm, which is the side effect or even withholding a beneficial standard treatment so that the patient is worse off through taking part in research. And the psychological, which is the fear of the unknown of having made the wrong decision, and the corrosions or the forcing the patient. Also, there is the harm to the environment, which can negatively impact our patient health. So, for the informed consent, which is very important to obtain in any clinical trial in which we will have participant or a human subject participating in the study. So it is defined as a process by which a subject voluntarily can confirm his or her willingness to participate in a particular trial. This is after having been informed of the aspects of the trial that are relevant to the subject's decision to participate in this particular trial. So informed consent in clinical research is documented by means of writing a signed and dated informed consent form. Another important ethical consideration is the respect for autonomy, which is the self-rule, and a person should be free to make their own choices and decisions and free from the pressure or interference from others. They should be provided that they have mental capacity to make the decision and the information that are required to enable them to make this decision. And it can cover issues such as the consent, choosing the treatment regimen, deciding to refuse a life-saving therapy, and willingness to make part in a trial. Also, the power of the right of self-governance, which is possessed of a reason to give law to themselves, is defined by the Webster Dictionary. So a person who is autonomous is capable of making their own decision and can make their own choices. Also, to be encouraged, not just to passively allow any research participant is rather recommended. So the non-autonomous group or those with limited autonomy are said to be vulnerable groups, and they are discussed in details rather on that we will be drafting upon. So for an informed consent to be valid, it doesn't need to be just informed, but rather should include full information about the study, clear information written in plain English, understood and non-corrosive. Also, it should be recorded and continuing. This means informing the patient of any new changes that occurred to the research design or any implications with the research implementation. In addition to this, honesty and integrity is of paramount in clinical research. So there should be no deception and no corrosion with no endorsement or, for example, giving the participant large amount of money to participate in the study. Also, the participant should be free to withdraw at any time without giving reason or care of being affected, negatively affected. And they should be informed of this from the beginning when they are enrolling in the study. So as we touched upon previously, there are some vulnerable groups that need to be, that we should take extra care when we are enrolling in our studies. These include the cognitive vulnerability groups with minors, elderly, or people with any mental problem. Also, the medical vulnerability, such as those severely ill in the emergency care or when there is no cure available at all. In addition to this, there is the institutional vulnerability, which is the military personnel, the prisoner, the hospital inpatient, and children in school. Also, the diurnal vulnerability, which is due to dependency, participant being on patient or student you teach, for example, or even a family or social hierarchy. In addition to this, there is the economic vulnerability, which is in low-income group or even the elderly are considered upon this group. Also, the social vulnerability, where people with mental or behavioral problems are included, and the ethnic minorities, especially due to language problems and etc. Also, the situational vulnerability due to current job, family state, or emergency situation. Often these will be time limited personnel and may agree to participate just to save their times. Also, justice, in which the healthcare that is largely related to access to medical provision or the insurance where it is required. So justice would seem require fairness and equality, but the healthcare provision is considered as a cost-restricted service. So it should be available to each person equally sharing and according to their need and their contributions. And the approaches to the ethical principles depend upon the right based, which is allowing the enthusiastic on request, allowing people to volunteer to be harmed, or even the Human Rights Act that is adopted in the UK. And according to the NHS, the ethics protocol withdraw on all of the three approaches by defining the rules and the codes that become predominantly duty-based one. So why do we need a formal ethical review process? This is considered as an independent external viewpoint, and it should identify unintentional problems such as corrosion, the burden to participate, bias, scientific validity, or even the public confidence in the research team. So for the risk assessment, this should include assessing the hazards, which are the features that has the potential to cause harm, and also the risk, which is the likelihood that the hazard will actually cause harm, and assessing the consequences, which is the outcome of the harm if it should occur, with multiplying the consequence with the risk analysis to assess for as defined as a risk assessment. So what can be risk assessed? These can include processes such as venipuncture, equipment, or even the patient themselves, the medication, the facilities such as the patient room, or even the study in general, including assessing the ethics of the study. So how can we minimize the risk? This can be minimized by assessment, by assessing the medication, the preclinical work, etc., and also by assessing the dose, the control group, the communication, and the pharmacovigilance with the procedures of the service. So for the risk minimization, in an example of boiling the tea, when we boil the water, we need to limit the quantity to avoid overspilling of the water. And we should assess the electrical supply as the safety check. And we should assess, for example, if we have any allergies, which is the participant awareness, or also the spillage or breaking, which is the safety check, and including training in general. So what is an informed consent that should be given to all participants? This is a process by which a subject can voluntarily confirm their willingness to participate in a particular trial after having been informed of all aspects of the trial which are relevant to the subject's decision to participate. Also, informed consent is documented by means of a written, signed, and dated informed consent form. So why is it important? As we mentioned earlier, there were some negative impact upon the startness of the medical research field, such as the syphilis study, the Benjamin studies, which all have led to the development of the current clinical practice. So there are these four philosophical keys which we have mentioned and therefore can define the ethical principles of research. And these are the new clinical trial regulations that were based upon the negative impacts or development in the negative impacts of research that has occurred over the years. So, in summary, the consent for research has evolved from historical events, which are now embedded in the law, and also is defined as the underlying foundation of the GCP and can apply to all research studies, not just the clinical trial ones. So, for an informed consent to be valid, it must be informed, meaning all information are included. It must be competent, and it must be voluntarily, meaning that the participants were not forced to sign this informed consent. So the capacity to consent to participate in a research will depend upon many factors. This includes the participant mental capacity, which is their ability to make their own decision, and the law states that a person is unable to participate or make a decision if they cannot do one or more of the following. First is understanding the information given to them, retaining that information, weighting up the information that is available, and communicating their decision. So researcher must be able to assess the capacity when recruiting the participants or seeking an expert advice. So this is of paramount importance in clinical research. So the responsibility of the consent is the is ultimately dependent upon the principal investigator, but also everyone involved in the consent process must be trained and competent to perform their specific role. They must have evidence of consent training. They must maintain the competence and keep updated. They must know the protocol and they can delegate this task to their superiors. So the participant information sheet should include a version control, which is approved and dated, localized form, which can include the trust logo, and it shouldn't change unless there is minor typos, and it should include the contact details of the principal investigator, and they should all be quoted. In addition to this, everything should be documented in the patient notes, including the date and the time, the patient identification number for any possible inclusion in clinical trials. In addition, it should be verified with all inclusion and exclusion criteria. And also the patient information sheet should be given a version number to obtain or even record any minor change that has occurred. Also, we should clarify when to follow up that will take place, and we should inform the patient of this in a reasonable time scale so that they can make it to this follow-up appointment. Also, the study team contact information must be included in this informed consent so that if the participant needed to inquire about anything, they can get easily access to information or answer any uncertainties or concerns. So we'll be taking a break now for Salat al-Maghrib, and then we'll continue with our webinar. Assalamu alaikum wa rahmatullah. Welcome back, everyone. So, after discussing or having an introduction about medical research, and after discussing the ethical concerns regarding research, we will continue of the critical appraisal of the research in general. So, critical appraisal is built upon the evidence-based medicine, which is consistent and explicit with the justice use of the current best evidence in making decisions about the care of individuals, patients, or even integrating the individual clinical expertise with the best patient fit or available external evidence from any systematic research. So it integrates three parts, which is the individual clinical expertise, the best external evidence with the patient value and expectation to have the evidence-based medicine that is built upon the critical appraisal. So there are different levels of degrees of evidence that is based upon the type of the study design. So the efficacy of an intervention is the strongest in the systematic reviews, that is of the randomized clinical trial, followed by the systematic reviews of the single trials or any systematic review in general. That is followed by the controlled clinical trial cohort, the case control, the cross-sectional surveys studies, and the case reports, which is considered the less accurate type of studies that is based upon the fact that it only relies on one case, which is case report. So what is a systematic review? These are scientific investigation in themselves, and they synthesize the results of multiple primary investigations by using strategies which limit the bias and the random error. So these strategies include a comprehensive search of all potentially relevant articles and the use of explicit reproducible criteria in the selection of articles for review. Also, the primary research design and study characteristics are appraised, which are data that are synthesized and resulting in the interpretations. So how is this different from the normal literature review? These are usually based on one individual opinion of the current state of knowledge, and these are inventively limited and from a partial perspective only. And it can offer combining results which can increase the power and the precision of estimates of effectiveness. And when there is few or even no study found, this can help to pinpoint the crucial areas and the questions that need further research for a particular problem. So the process of a systematic review starts with a question, a need to check or state objective, outline the eligibility criteria, and developing a protocol. Then we will search for the result or the studies and assess for the inclusion criteria or the exclusion, then comply with the data set according to the quality and the analysis results, in addition to using meta-analysis and subgroup analysis, depending, of course, on the type. Also, the structure of the report of the review is of crucial importance, which need to be decided from the first status of developing the review. So, is systematic review beneficial? We need to ask the following questions. Did the review ask a clearly focused question? how well have they searched for all the studies which might be relevant, and how will have the studies been filtered to be selected in this review, and has the quality of the studies been assessed, or have all the results been combined. So there are some tools that can be used to help in this process, which is the CASP tool, and these are found to be very helpful in checking for the accuracy of these criteria. So the effect of review, an example of this is the SALT evidence that has been interpreted in various different ways. And this review on the effect of salt reduction advice on the blood pressure and CVD, and even the mortality, has been interpreted to suggest that even though that salt is an important predictor of blood pressure, the advice to reduce salt is not very effective in large populations. So the effectiveness of this has not been rigorously tested, but rather on a general systematic review point. So when to pull our data, we only need to combine the numbers from studies which we believe to be asking the same question. And sometimes, even though that studies can appear similar, but give very different answers, therefore, this should be investigated carefully. And sometimes, even though the studies can appear similar, we need to look out for this when we are performing a meta-analysis in specific. So the heterogeneity, which is the change in the data that we are obtaining, will depend, of course, on the odd ratio or the CI, which is the confidence interval of any study. In addition to this, there are also stratified tests for the heterogeneity, which is the chi-square test of heterogeneity that is set to a p-value of less than 0.10 that demonstrates statistically significant heterogeneity. Also, they may not be appropriate for pooled data, which is gathering a lot of information. And the most used measure of heterogeneity is called the I2, which describes the percentage of the total variation across studies due to the heterogeneity rather than due to chance. And a value of 0% can indicate no heterogeneity at all. We will just be taking a quick break for 5 minutes and then we will continue. Assalamu alaikum. So, as we were saying, an example of the heterogeneity is the systematic review that was conducted upon the effect of salt reduction on blood pressure. This study has resulted in a 95% confidence interval where the test of heterogeneity was found. Therefore, if this effect was found, then we shouldn't conduct a meta-analysis, and we can explore the causes of this heterogeneity through subgroup analysis method. And we can also always do a narrative synthesis to simplify these data. So a clinical focused systematic review study should be assessed for their grade. And the grade assesses the quality of the evidence and how confident we are in the answers that are provided by the review. That can be high, moderate, low, or even very low in some cases. So the grade assessment is the summary of, we believe that the results of the study is valid, as that can imply the risk of bias. Also, are the results consistent across different studies, which is the inconsistency? And are these all of these the available studies on this subject, which is the publication bias? And is the effect size precise, which is the imprecision? And how do these results apply, which is the indirectness? So an important source for appraising a systematic review is the Cochrane Center, which is an international non-profit organization that prepare, maintain, and also disseminate the systematic up-to-date reviews of the healthcare interventions. And mainly, and not exclusively, they review randomized controlled trials. So this is considered the best source for appraising systematic review and can be accessed through the following website for their library. So their wider role, they play an important role in training and supporting systematic reviewers, increasing the numbers of systematic review and coverage of clinical areas, developing methodology, and producing systematic reviews that are updated consistently. So, on overall, a good systematic review can inform our clinical practice individually and via their guidelines, inform the research agenda, and consider the best place to look for evidence which can be useful and well cited with the publications. So after discussing all of the major points regarding research, we will now continue with the quantitative research study design. So first of all, quantitative studies are based on the scientific methods, and they use this deductive reasoning where the researcher can form hypotheses, collects data in an investigation of the problem, and afterward uses these data to investigate after the analysis is made and the conclusion are shared to prove the hypotheses are true or even if they are false. So there are four types of quantitative designs, which are the experimental studies, which are considered comparative studies, the correlation studies, and the survey. So these are the major four types of quantitative study design. So from the name, quantitative mean it focus on the quantity, not on the quality. So the higher the number is, the better this type of study design. In the experimental studies, these are often called experimentations and uses the scientific methods to establish a cause-effect relationship among the variables in a research study. Also, researchers make an effort to control for all variables except the ones that are being manipulated, which is also the independent variable, and the effect of the independent variable on the dependent variable are collected and analyzed for their relationship in general. So the major features which distinguishes experimental research from other type of research is that the researcher can manipulate the independent variable according to the point that they are studying or considering. Also, in this type, the subjects are randomly assigned to the experimental treatment, meaning these are blinded study type in general, and experimental design should be developed to ensure that the internal and the external validity of the study is assured at all times. So what is the internal validity? These are the results of the study that is caused by the factors included in the study, or are caused by other factors that are extraneous variables, which were not part of the study, but were later on found to have some sort of effect on the study variable. So the extraneous variables are unwanted variables which may have an effect on the experimental outcome. For example, if we were worried about the gender, we can only include one gender in the study to have a more focused study observations in general. So there are some threats to this internal validity of any study. These can include the subject characteristic regarding the selection bias, and the group can have can be different from the start if we were testing for instructional strategies to improve reading, for example, and one group enjoy reading more than the other, then this can improve their reading because they will enjoy it rather than the instructional strategies that they used. So this all can affect our selection bias, and this can be considered as unintentional bias due to the fact that we couldn't have known the participant, for example, will enjoy reading. There is also some other issue with the internal validity, which is the location. And perhaps one group was at a disadvantage because of their location. For example, they couldn't attend all of the follow-up sessions due to a longer driving period or inappropriate timing for them of the day. There is also the instrumentation's decay, which is testing the instrument. They may not be scored similarly, meaning that if we were conducting a study measuring blood pressure of the participant, one center may be measuring using an electronic blood pressure measuring device, where the other center will use normal or regular methods of assessing the blood pressure. Therefore, we will have discrepancies in the measured blood pressure. There is also the data collection bias, the collector bias, sorry. So this is the person who collects the data and may have favor to one group or some characteristic of some subjects that possess over another. And example of this is a teacher who favors strict classroom, for example, management that can rate that student attention under different teaching condition with bias toward one teaching condition. Also, there is the resentful determination of the control group, which is that it can become discouraged due to its not receiving the special attention which is given to the treatment group. And as such, they may perform lower than the usual because of this issue. And once that the researchers are confident with the outcome of the DV of the experiment, then they are designing the results of their treatment with the internal validity, and they can determine for which the participant or the situation with the results of their study that apply to the external validity. While for the external validity, these are the result of the study generalizability, which can be applied to other populations and settings. This can come in two forms, which is the population validity and the ecological validity. The first one, which is the population validity, is the extent to which the result of the study can be generalized from the specific sample which was studied to the larger population. Where the ecological validity is the extent to which the result of an experiment can be generalized from the set of environmental conditions that are created by the researcher to the other environmental conditions or the setting of the conditions. Each of these validity issues have some sort of threats or issues that they can face. The first one in the external validity is the pretest sensitization, in which that a treatment might only work if the pretest is given. And due to the fact that they have taken a pretest, then the subject can be more sensitive to the treatment, or they hadn't taken a pretest, then the treatment would not have worked. Also, measurement of the DV can be that a treatment may only be evident with certain types of measurement. For example, a teaching method can produce superior results when its effectiveness is tested with an assay test. So first and foremost, an experiment must have an internal validity check. And if the researcher cannot be certain that the results of the experiment are dependent on the treatment, then it doesn't matter to which people or situation they wish to generalize these findings. And the importance of the external validity is that they rely on having internal validity in much the same way that the validity of the measurement instrument is reliant on the instrument being reliable in general. So there are different research designs in the quantitative methods. One-shot study design, the one group pretest post-test design, and the statistic group, the conversion design, the randomized studies, and the randomized pretest study, or even the four-group design. So an important part of quantitative study is animal testing rather than starting a clinical trial with humans. So testing animals is done in any pharmacological clinical trial, which must be conducted before carrying this type of studies in human participants. So why are they used? This can help to understand how drug behavior in vivo specifically work, to capture the pharmacokinetic data, to assess the toxicity, and to assess for the efficacy of the studied medication in specific. So the pharmacokinetic and the toxicity data can measure the exposure at different doses, including the absorption, the distribution, metabolism, and the excretion. It can also help in defining the tolerability and the safety with the maximum tolerated dose, including the well-being and the tissue damage of the studied animals. And in addition to this, the duration of the repeated dose toxicity studies to support phase 1 and 2 trial in Euro and phase even up to 3 in the US and Japan is conducted. So the duration will, of course, depend on the type of the rodent or the animal and the duration of the clinical trial. So this timetable should be followed upon conducting an in vivo clinical trial. So in the repeated dose preclinical studies, these commonly have 3 dose levels and a vehicle, which is a low dose that should be non-toxic but small multiple of estimated therapeutic doses, or it can have a high dose that should be sufficient to cause toxicity but not death, and an intermediate dose that can be given to observe medium effect. So a detailed observation of the physical condition, growth, and behavior of the biochemistry and ECCG, for example, should be noted. So some of the common terminology will be the NOEL, which is the no observable adverse effect level, and the HED, which is the human equivalent dose, the MABEL, which is the minimum anticipated biological effect level, the MRSD, which is the maximum recommended starting dose. So we will be discussing these terminology further in details. So the NOEL is defined as the highest dose level that doesn't produce a significant increase in the adverse effect in comparison to the control group. It also refers to the biologically significant rather than statistically significant dose. For example, it doesn't have to be statistically significant rather than having an observed effect. Also, it referred to the biologically significant rather than statistically significant, and it can distinguish from no observed effect level that it may be effective in animals with a lower observed dose. So there are 3 essentially types of finding in a non-clinical toxicology studies which can be used to determine the NOEL. The first is the overtoxicity, which can occur in clinical design, in microscopic lesions, etc. The second is the surrogate markers of toxicity, such as the serum liver enzyme level. And the third is the exaggerated pharmacodynamic effect. Wherefore the HED, which is the human equivalent dose, after conducting the NOEL in the relevant animal studies, these that have been determined, then these are converted into a human equivalent dose compared with the animal dose. So it is assumed that the toxic endpoint for the therapeutic administered systematically to animals, such as the MTDs, are usually assumed to scale well between species when the doses are normalized to the body surface area. An example of this is for the antioblastic drug, which have a lethal dose to 10% of the rodent, and the MTDs in the non-rodent both correlate with the human MTD when the dose were normalized to the same administration schedule. So HED is calculated from the NOEL in the most appropriate animal species using the body surface area conversion factor. And the most appropriate species is usually the most sensitive, but occasionally for biologic studies, another model is more relevant is being used, such as the genetically manipulated animals to have certain disease. So this table is used for the conversion of animal doses to human equivalent dose based on the body surface area and should be followed in quantitative animal studies. So the converting to milligram per squared meter for the body surface area in the first step to convert it from mg to kg and to mg meters. This is multiplied by the conversion factor that indicated as kilometers for the mass constant. So this factor has a unit of kg per meter that is equal to the body weight in kg and divided by the surface area in meters squared, following the followed formula. And for example, this method can be different if we were using dogs as experimental animals. So the dose can then be converted back to the real value in the humans by dividing the dose to the factors for human that was just mentioned in the previous table and having the following formula to calculate the appropriate dose. So the human equivalent factor can be calculated directly from the animal dose by dividing its dose by the ratio of the human animal kilometer factors using the following table in the third column. So these are pre-specified factors that we only multiply our dose with to have the appropriate dose for humans in clinical trials. After that, we will apply a safety factor, which should then be applied to the human equivalent D to increase the assurance that the first dose in human will not cause any adverse effect as a result of the bioavailability and metabolism that will be different significantly from that of an animal. Also, the mechanism of toxicity that cannot be known, for example, the toxic accumulation in peripheral compound or tissues. Also, the toxicity that may be due to an unidentified metabolite, not the parent drug, and the toxicity that can be difficult to detect in animals, such as headaches or ocular problems, etc. Wherefore the MRSD, in general, one should consider using a safety factor of at least 10. And dividing the HED by the safety factor can give us the MRSD. But the safety factor can be increased if the following is present, including inadequate dose response, novel therapeutic target, or the animal models with limited utility. Also, the steep dose response curve, the severe toxicity, or the non-monitorable toxicities, or even without any previous signs, or due to the bioavailability of the drug, or even if this drug has an irreversible toxic effect on the study. So the efficacy studies will focus on answering a main question, which is there any signal signs of desired effect? And it will rely on animal models of disease of interest. So why does the animal studies fail to predict efficacy in humans and why we cannot rely on them only for assessing an impact of a study. So, animals are not miniature to humans and will have differences in metabolic pathways and their drug metabolism, leading to variation in efficacy and also in toxicity. Also, they will have inadequate knowledge of the cause of a disease, meaning that it is difficult to reproduce the human conditions, and it will have differences in the routes and doses of administration compared to humans, with also lacking robust study design, such as method of randomization, blinding, and the choice of conversion therapy, such as placebo, for example. Also, there are small experimental groups with inadequate statistical power, such as simple statistical analysis, which doesn't account for the confounding and failure to follow the intentions to treat even the principles. Also, it can have outcomes of measures of uncertain relevance to the human clinical conditions, and animals don't report on the subjective effects, such as we mentioned, headaches and the variable duration of follow up, which may not correspond to the disease latency in humans. So, we need to humanize the animals for some treatment to have an appropriate assessment of the effect in general. So, this is the reproducibility of any drug or relating to from animals to human, and the percentage for the research survey yearly on selective reporting and the published reporting. These are also some summaries for studies which has reported the corrected experimental measures that should be used. And as we can see, there are reviews of study designs, including that the randomization were becoming less frequently seen, where blinding was considered the highest to be used in general, and the inclusion of both gender was less frequently seen. So to improve the bioscience research reporting, then the ARAV guideline for reporting animal research has been conducted. This will, of course, depend upon the study design, the experimental procedure, and the experimental animal that is being used in the quantitative studies. So all of these should be followed for each experiment to have a reproducible, reliable effects in general. These are also some of the other guidelines that depend upon the housing, the sample size, and the allocation or the statistical method that is being used. In addition to this, the baseline data and the number of analyses with the outcome estimation and also the adverse event are of paramount importance and should always be included in the bioscience of research reporting in the quantitative data. And of course, there are some alternatives to animals, including induced blueprints of the stem cells by creating disease on an isogenic background. Also, the organ on a chip method, which combines cell types on a scaffold. And in the in silico studies, which are computer models of a disease with network medicine. Also, the human as an experimental subject is a method with microdosing or the pharmacological challenges, or even in imaging studies. So another important point of view in quantitative study is the use of biomarkers. So the biological markers are a characteristic that is objectively measured and can be evaluated as an indicator of a normal biological processes, or even of the pathogenic processes or the pharmacological responses to a therapeutic intervention. So there are different types of disease biomarkers, including the susceptibility risk of developing disease, such as the BRC mutation for breast cancer, or through screening to detect any subclinical disease. It can also be done through diagnostic recognition of a disease with, for example, blood troponin of myocardial infarction, and staging, which is categorizing the disease severity and the prognostic predicting features of the course in response to therapy. This can include the brain peptides and heart failure. So, what is a surrogate endpoint? This is a laboratory measurement or a physical sign that is used as a substitute for a clinically meaningful endpoint, which measure directly how a patient feel, function, or even survive. Also, changes induced by a therapy on a surrogate endpoint are expected to reflect the changes in a clinically meaningful endpoint. So, what are the advantages of this method? In this method, every patient has the surrogate, and so the number of patients required to demonstrate an effect should be smaller compared to other types of studies. Also, the effect of an intervention on a surrogate endpoint can be measured much sooner than the clinical endpoint of interest. There are also, on the good clinical practice that we mentioned, or the FDA, an approval based on the surrogate endpoint or an effect of a clinical endpoint. So the FDA can grant marketing approval for a new drug product on the basis of adequate and well-controlled clinical trials, establishing that the drug product has an effect on the surrogate endpoint, which is reasonably likely to predict the clinical benefit. An example of this is the ectopic beats as a surrogate clinical endpoint. So the reduction in the ventricular ectopic contraction can be used as a surrogate clinical endpoint for decreased mortality rate. An example of this is the CAST trial, which is the cardiac arrhythmia suppression trial that evaluate how eccansanide, flaxenide, and neuroside would affect the survival of patients who had MI with more than 10 premature ventricular beats per an hour. So early results of this trial were startling as 33 sudden deaths in patients taking either of these medications compared to 9 in the matching placebo arm. And a total of almost 60 patients died in the NSAID or the flumanside arm compared to 22 in the placebo. So the final analysis with the results showed that an increased risk of death for the microzyme arm can also occur. So assessing the biomarkers can be of a great importance or great impact in quantitative studies or medical studies in general. But of course, any condition or any markers can fail in some cases. And an example of this is the lack of the causal relationship. An example is in the ischemic heart disease and the clinical endpoint of sudden death. This could have been affected by any other impact during the treatment period in general. So the intervention effects can only have one effect, which is the MI in the previous case, which has been studied. and therefore other effects cannot be assessed, such as intervention bypassing the biomarker in general, and therefore didn't detect the true effect. Also, a confounding adverse effect could have been present, and this could have been unknown and therefore wasn't assessed, and its impact wasn't taken into consideration. So there are some values of success in clinical trials, as once a biomarker is validated as a surrogate endpoint, it is considered easier to employ in any subsequent decision-making studies, therefore will improve clinical studies in general. But also using a validated marker to other drugs for the same clinical indication needs careful consideration. And they can have different mechanism of actions with different chemical structure that can have an effect on the patient condition in general. There is also another approach which is the multi-marker approach. And in this type, there is no single biomarker surrogate endpoint that is likely to capture all of the effects of a therapeutic intervention on a clinical endpoint. So for efficacy, an example of this is assessing serum cholesterol, and an additional biomarker can be the CRP, which is considered for high sensitivity, and another biomarker for toxicity. So adding more than one biomarker can also help in improving the result that we are observing with more, bringing more validity to the study. So the quality of the science required to demonstrate the value of a new biomarker is similar to that required to support the validity of new therapies. Also, there is a need to access a well-phenotyped patient population to conduct any epidemiological associations with statistical power. Also, the assays need to be robust with biological plausibility and evidence of a mechanistic link. An example of this is the lipoprotein-associated phospholipase studies in atherosclerosis, where the candidates were targeted for validation in general. So this was greatly upregulated in the high-risk coronary artery lesion and was found to have a reduced complexity of the coronary lesions in two animal forms of studies in a control group and also another interventional animal group. So the direct inhibition was found to be in the pre-surgical dosing of patients undergoing this treatment. And the representativeness example of the blocker composition in the durable and the placebo-treated group were observed in general. So the key messages is that biomarkers are now commonly recognized term with which are considered also valuable for reducing the size, the duration, and the cost of clinical studies. In addition, the blind use of biomarkers can lead to the wrong decision. Therefore, it needs to understand the limitation of each biomarker and therefore deciding the most appropriate quantitative study design for this type. Also, it needs to be validated and used in the right context with the fit for purpose method to be applied in general. So after studying that most of the medications that are being studied are first implemented in quantitative animal studies, every drug development can take a very long pathway until it is approved for human use. These will include the pre-discovery and the post-discovery phases, depending, of course, on phase 1, 2, and 3 trials. So in the first, every drug discovery can take up to 10 to 15 years with the discovery phases. And in the early stage of the research and the discovery, this will focus on the feasibility, the developmental status, and identification of the medication, or even optimization of its full potential. After that, there is the animal studies, as we discussed, for the kinetic toxicity and the mechanic studies of the drug mechanism of action. And if this was approved, then we will continue to the phase 2 or 3 trials, which is the safety assessment trial. So in phase 1, which is the human pharmacology phase, it's focused on the objectives of assessing the tolerance, defining and describing the pharmacokinetic and dynamic, exploring the drug metabolism and interaction, and estimating the activity of the drug. An example of this is the dose tolerance studies, the single and multiple dose for pharmacokinetic and dynamic studies. And in phase 2, which is the therapeutic exploratory phase, this focus on exploring the use of the targeted indication, estimating the dose for any subsequent studies, and providing the basis for confirmatory study design, endpoint, and methodology. An example of this is the earliest trials for relatively short duration in a well-defined and narrow patient population using a surrogate endpoint. Where in phase 3 trial, this is defined as the therapeutic confirmatory status. These focus on demonstrating or confirming the efficacy of the medication, establishing the safety profile, providing adequate basis for assessing the benefit and the risk relationship, and establishing the dose-response relationship. Example of this is studies for mortality and morbidity outcomes. In addition is the final phase, which is the therapeutic use. This can focus on defining the understanding of the benefit and risk relationship in general or in special populations. It also focuses on identifying the less common adverse reactions and refining the dose recommendation. So in the single and multi-dose escalation studies, these typically considered the first in-human studies. These also should be randomized, placebo-controlled in healthy volunteers or patients in certain cases. Also, starting dose is determined by the preclinical toxicology studies, and the information gained can help in deciding the safety and the tolerability, with the maximum tolerated dose being identified in this phase. Also, the general PK characteristic, the variability, and also the state of the parameters, which is the accumulation or the time dependency. So in each stage of any clinical trial or any medical study, we will gain a lot of information that will be helpful in deciding our intervention goals or outcomes in general. So additional information to inform the regulatory approval is obtained in the preclinical trial, for example, or depending, of course, on the phase of the intervention. And an important part of this is the food effect studies. which focus on evaluating the effect of food on rate and extent of drug absorption from a given formulation. Also, in the single dose crossover two treatment studies or two periods, it can be helpful in the food effect study and assessing the Becky and the confidence interval of the food effect. In these studies, we can gain information regarding the effect of food on the BA of the oral agent and labeling the instruction on whether to administer drug on an empty stomach or even without regard to meals. Also, in the mass balance studies, the objectives can focus on understanding the full clearance mechanism of the drug and its metabolites in humans. In addition to this, these can typically include single-dose healthy meals at intended route of administration. And we can gain information regarding the primary mechanism of elimination and the excretion from the body, with also the proportion of the parent drug that is converted to metabolites in general. So also these can be helpful in the BK in pediatrics or even in renal impairment or hepatic impairment. These can also be implemented in the in vitro status. So in the renal impairment studies, which is a specified type of studies, this is a single dose study of the parallel group, which is the healthy males and females with varying degree of renal function. These can be helpful in obtaining information regarding the effects of renal impairment on the drug clearance in general, including the appropriate dose recommendation for various stages of renal impairment. Also, we can gain information regarding the effect of hemodialysis on the drug exposure, or even information on whether the dialysis could be used as treatment for the drug overdose, meaning it can be helpful in the drug clearance in general. Where in the hepatic implementation studies or impairment studies, this can include full studies with single dose if there was linear time independent studies, and it can include both genders with varying degrees of hepatic impairment. So we can gain information regarding the effect of hepatic impairment on the pharmacokinetics of the parent drug and its metabolites. Also, we can gain information regarding the recommended dose for various stages of hepatic impairment in different patient groups. So the ideal drug characteristic of the absorption can be that it should be highly absolute bioavailability with low variability, or even it can exhibit linear pharmacokinetic over the therapeutic dose range. An example of this is the dose of proportional increasement in the Cmax or the AUC. Also, in the single dose studies, the design of a sufficient bioavailability, the renal impairment effect, and the hepatic impairment can be indicated. Also, another major point for observation is the distribution of the drug in the body. So, researching the target site of action immediately and at effective non-toxic concentration is of paramount importance. And we should always assess that it doesn't accumulate in the non-target organ as a side effect. So the drug must be local in its action or application of advantage over systematic administration. And also it shouldn't significantly bound to the plasma protein with extent of protein binding, not the concentration and the time-dependent studies in general. Also, we should assess the drug metabolism and excretion from the body as not extensively metabolized or exclusively metabolized by a certain enzyme. That should be the goal when developing a drug. Also, the clearance is less likely to be affected by the hepatic impairment or the concomitant of administration of other drugs, which can affect one or more of the metabolized enzyme. Also, clearance, not wholly dependent upon the renal function, is the desired goal in general. So we shouldn't have a narrow therapeutic index drug. It should have a great margin of safety and less likely to require therapeutic drug monitoring, with also no significant inhibitors or inducers of certain enzymes. And it should be less likely to have interactions with administered drugs. And it shouldn't trigger inflammation of the neutralizing anti-drug antibody or organ damaging as a side effect. So when administering a drug, there is a therapeutic window in which the timing of the drug can exert its effect without causing toxicity, with the rate also of the clearance of the drug from the body. So how can we address the high attribution rates in medication intake? In the drug development, it is a high risk for business to have a high attribution rate, as these studies are more likely to be rejected as an unsafe study design in general. So the drug should have a valid target, a biomarker of engagement and mechanism, and it should identify the patient population in which the drug will not cause any significant side effect, for example. So what is the importance of a valid target? Selecting the right target remains the most important of the 5 Rs and the most important investment decision that we can make in quantitative clinical trials that involve developing medications. These include assessing the risk, the validation the target, or even reproducibility of the target effect. So the value of understanding the mechanism depends upon the pharmacokinetic predictive accuracy and projecting on with or without proof of mechanism, depending, of course, on the phase of the clinical trial. So to validate the target, the evidence of association is limited to the value. And because, for example, protein X is elevated in BAH carriers, has no weight at all in assessing the target of the validation. Also, lacking the predictive value of isolated cells and non-human species is considered a problem. And knocking out genes in cells or animal remain the most common attempt to validate the target for drug development. So the knocking something out can often not represent a pharmacological modification, but rather have a hierarchy of evidence on the target validation of the drug. So as we mentioned, clinical trials can have proof of concept in humans, and using human subjects can have evidence that the target can cause the disease, and usually, but not always, can have some form of genetic evidence. where in vivo studies, the evidence that the interaction with the target can result in the desired change in the animal models, while in vitro, the evidence that the interaction with the target can result in the desired change in the vitro, and in the theoretical part of the quantitative studies, the prediction based on general understanding of the biology is considered the more focused point of consideration. So what is the importance of having a genetic linkage in quantitative? This can have increased success rate in any type of interventional clinical studies, and selecting the human appropriate knockout factors will result in the effect of a more biomedical effecting or promises in the treatment that is being developed. Where also this can have some importance in the case of rare diseases, as the case of the orphan drug designation or the orphan gene, which come with the birth of the drug compromising that can find cure for rare diseases, therefore can be implemented in the clinical trials case. Also, this can be assessed for the variability in the response to a certain medication and can be assessed based on the Cmax, which is the point of effect, and also the duration in which the drug will be excreted from the body. So the response rate to any medication for different disease should be also assessed as an effect for the excretion, or to even assess the exact effect when the medication will have its effect. An example of this is that in diabetes medication, the response rate will be 40%, where in cancer medication, for example, the response rate to the medication will be 75%. So, in quantitative study, stratified medicine can refer to the targeting of treatment, including the pharmacological and non-pharmacological interventions. This can be according to the biological or the risk characteristics that are shared by the subgroup of patients which are being studied, for example, in this type of research. So an example of this is the differential response to or predicted response of the calcium, for example, antagonist in the PAH cases. This can be assessed in the changes or the percent of change from the baseline to the effect or the novel effect and the excretion rate in general. Another example of this is the GIST and the FDG PET scans that predict the response to certain medication. In this type of studies, we will take, for example, assess the patient in before the treatment administration and after a certain period of follow-up after implementing the change in the clinical trial, and after the followed point or having two follow-up points to predict some certain change or effect. So there are many factors that can influence the medicine response in quantitative studies. The first one is the genetic differences between the patient. So if we have a clinical trial type of research, then we will have different type of samples or populations. And of course, all of the sample cannot have the same genetic variability. Therefore, this will be one of the factors influence our target evidence. The second is the interaction with other medications, including, for example, if the patient have other disease, and for example, if we are assessing chronic heart disease in this type of studies, and the patient is also diabetic, then the interaction of these medications can affect the result of our studied research. Another important point is the dose of the medication and also the diagnosis with the adherence of the participant in the study to the applied intervention in general. So a historic background regarding the effect of medications in quantitative study is the century described phenylkinatic model in the blindness test in the late 1930s, which can also extend to the hemodialysis studies that affected the deficiency of the G6 enzyme, and also the pharmacogenetic combines of the succinyl ammonia and the serum cholesterol deficiencies until late in the 2030, where the human genome study was published in order to have better understanding of the human disease. So as we can see, over the years, the interest in genetic and medicine research have increased rather than the previous studies, which only focused upon the medicational intake of certain research studies. So the nomenclature types of study or the type of quantitative study will focus on the pharmacogenomic, that is the pharmacogenetics of the study. And with only 2 single nucleotide polymorphism, this can affect the observed effect of the medication that we can assess in any type of clinical trials. And therefore, these genetic variation can influence the patient response at 2 levels. These include the first one, the absorption level, and then the response impact. So in pharmacokinetics, the distribution of the drug metabolism is affected by the absorption, and this can be assessed by testing the participant blood level that is achieved. And then the pharmacodynamic is also affected by the response of the participant to the intervention that we have applied in our study. So as we mentioned, the distribution and the transport of the drug metabolism can affect our response. So genetic variation can influence the drug metabolism, therefore can influence our observed effect that we assessed in our study, for example. And any poor drug metabolism can be exposed to increased blood level of the medication, therefore can lead to toxicity or adverse effect. Therefore, this is why it is important when we are developing any type of medical research to assess the toxicity of the medication and the time of the execution. So why is the genetic variation in the drug metabolism is important? When the drug has a steep dose response curve, then this will affect the patient response. And if the drug has a therapeutic window that is narrow, then this will also affect the dose that we are given. And when the drug is metabolized mainly by one enzyme, then this will be affected depending, of course, on the genetic variation of the participated individual. So an example of this is the dibroxequine, which is only metabolized by one enzyme. Therefore, it is regarded as a highly risky medication with certain populations that cannot observe this medication. So the inactive or the active metabolites can also be affected. So upon developing a clinical trial, we should assess the drug for its metabolism, depending of whether it causes a catabolic or an anabolic metabolism. And this, of course, will depend on the type of enzyme that is being studied. An example of this is the TBMT deficiency, an enzyme deficiency. And 1 in every 300 persons in the UK have this type of deficiency with several polymorphism of the genes and can predict severe neutropenia following treatment with certain medication. So some cases of severe neutropenia can occur even with patients who have normal phenotypes, but are regarded as more sensitive and individual to this phenotype impact. So this is the genotype of this enzyme. And the certain medication, which is azithromycin, that is used in a wide range of inflammatory disease prescribed by specialists in respiratory medicine or even in dermatology, can have some effect. And the product labeling that was amended by the FDA in 2004 test has determined the TMBT status. And according to different organizations or associations, all patients who require this type of medication should be pre-tested or have a pre-treatment to determine their susceptibility to a side effect. Another important consideration in quantitative study upon choosing the sample is that the genetic variation can also influence the drug transport. So, as we mentioned previously, the drug target or the intermediate pathway can affect the response of the medication. And it can also affect the drug target in general, leading to different absorption. An example of this is the patient in kidney disease who can have a different size of the band in target, which will be difficult for them to even utilize this medication. So the genomic variation affecting the drug target can be different, with malignancies or even somatic mutation, such as in the BRAF structure or the infectious disease part. So, genomic can be used for more accurate diagnosis of cancer types and can be regarded as a useful method upon conducting clinical trials to assess the true impact of any drug. So, SNP is that different people can have different nucleotide or base at a given location on a certain chromosome. So how can we determine this SNP map? Or how we even use it to predict a response to the drug? So patients with a good response to drug X or even with poor response can have predictive of efficacy or poor response depending on their genotype profile. And there are some ethical issues regarding this concern, including that the Genomic England has its own independent ethic advising committee, which will advise the genomic board on the ethical aspect of everything that they do. And a series of engagement and involvement activities with the patient, clinicians, and other group about these issues is currently being undertaken, including the consent, the feedback, and also the sharing of the data. So regarding the consent, we need to ask if the patient really understands the implication and what if they change their mind at any certain point. Also, what are the implications for the relatives in general? In addition to this, we ask, for example, the vast amount of data that can be shared, the causative genes that are well known, and many variants which are unknown. Also, we should have a direct contact, referring physician or counseling, inquiring about these data and deciding which part of information that can be used or shared with them in general. So in the data sharing, we need to assess for the safety, the commercial explanation, and the implication for the insurance. Also, we should assess for the oversight by the Genomic Data Advisory Committee that will ensure any researchers who want to access the data and will go through rigorous identity check and uses their data to be closely supervised. There is also no raw genome data that can be taken away and can be kept within the Genomic England data structure with consistency undertaking its control. Also, only when there is data to be used for the patient care, this will be identifiable data and made available to them or to their medical team in general. And the patients are told with the anonymity that it cannot be absolutely guaranteed that their information can be shared with other parts of their medical team in general. So there are 10 commitments on the information to be sought from the customers. For example, the participant will not be asked about undergoing a predictive genetic test or to disclose any family member test result or any diagnostic test required, or even to disclose any predictive genetic test result which are made available after their policy has started for as long as that policy is applied in place. So we need for quantitative study to link the genetic variant to the disease, which is a major challenge, to have accurate phenotyping data that is critical, and to have genetic variation that can affect the drug response, and variation, which is a powerful tool for identifying any valid target, with ethical issues around acquiring the genetic data on the individual that require public consultation and also engagement. So after discussing all of the parts regarding the quantitative data, their design, their studies, and their sampling, we will continue with discussing the analysis and interpretation of these quantitative data that we have obtained. So the first important statistical analysis of this type of data is the t-test, which is an aid to the decision making. So statistical significant tests are mechanisms for helping us to decide whether or not what we have seen in a trial data can suggest that a true difference exists between two or more observed group or treatment or group of data. Or in more general, that a true effect is actually present on our data. So the analysis of this type of data means how we understand the results we have observed in our research. So all statistical significant tests are based on the same logical process. That is comparing the data we actually see with some prediction about the kind of data we would expect to see if the effect was actually true. So this is assessing the effect on the general population as well. So an example of this is the biomarker of data. The measurement of the level of biomarker, for example, in patients who are treated with two different drugs, as you can see in the photo, treatment A and the treatment B. We will calculate the mean observed value on these two data, which is the true effects in the data. And the mean value on the A is considered the higher in the sample of data, but also there is a genuine difference in the biomarker level with these of the two other treatments. So how can we decide if this observed effect is actually true or merely an accidental observation? So the first step in the logic statistical significant testing is to choose a test of stat that will be measured and in some sensible and relevant way, the effect in which we are interested in assessing. So in the biomarker example that we have just seen, we are interested in the mean value in the two groups. So we will choose as a test of importance the mean or the difference between the mean of the two values in the two groups. And to calculate that, we will calculate the mean of group A, and then we will calculate the mean of group B, and then we will multiply these of each other and have the required value. And the second step is to establish the sensible null hypothesis for the test. And this null hypothesis involves asking a question about what we would expect the value of the test of stat would be if there was actually no true effect present. And since that our test of stat is the difference or the mean between the two groups, then under the null hypothesis, the result would be 0. And then we should imagine a process of drawing repeated sample under that null hypothesis, and we will consider the possible values which we might expect to see for our test of stat under this hypothesis. So, more in details, we will suppose that we are able to collect a sample of biomarker data in circumstances in which the null hypothesis was actually true. So we apply this in analyzing all quantitative data. So the sample consisting of individual measurement of biomarker levels in two different groups of 10 patients with no true difference. We will draw a line and then we will set the 0 for the null hypothesis, and we will divide the line according to the number we are observing. So even though that we know that if the null hypothesis is true, then the difference would be 0 between the two groups. In any particular sample, we would not expect to see a value of exactly 0, but rather we will see some natural variability that would give us values close to 0. So this can be minus 0.9, and we will suppose that we are able to take a second sample of similar data, and under this same null hypothesis, we will probably see a slightly different result from the observed one due to natural variability. And if we were able to take a few more samples of similar data, and for each sample calculating these differences between the two means, then we would have seen a range of value. So this phenomena is known as the sampling variation, and the result from the inherent natural variability of most biological and medical measurement from patient to patient in any quantitative data analysis. And the variation within the same patient can also be assessed in different time points, of course. So if we could plot a histogram of 1,000 samples, this would mean that we will able to see even more values of any individual differences between the group means. An example of this is drawing a histogram of the analysis that we have conducted, and which will show us the frequency in which we will get the sample means of certain values. So this is how we will conduct a sample test of STAT under the null hypothesis. So according to what we have just discussed, we can think about the process of collecting an extremely large number of participant or sample data. And if we are prepared to make certain assumption about the nature of the underlying individual measurement, we can then find a mathematical curve which will fit the shape of this infinite histogram. And for example, if we suppose that our individual biomarker measurements have the same normal distribution and a common standard deviation, which turn out to be the appropriate mathematical curve, then the mean will be 0. So the standard deviation of the individual measurement and the sample size can be plotted on the following curve, drawing this curve over the histogram, which will show us the mean of the sampling distribution. So this is determined by the mean of the population from which we draw the sample, and its standard error or the spread that is function of the A, which is the underlying standard deviation, and also of the sample size. And most of the significant tests are based upon such mathematical curves, which will represent the sampling distribution of the test of STAT under the null hypothesis. So when we analyze any data, we need to test it against the null hypothesis in the following, in such a following histogram or curve method. So the curve can show us the test of STAT values, which may have been seen if the null hypothesis is true, and it can show us the relative probability of getting certain values. And we can then ask ourselves whether on this curve of possible test of STAT, then the result we observed will actually be detected, which is in this case, the difference between the two group means that was 6.9. So then we can ask whether or not this value is unusual in relation to the curve that is showing with the various possibilities, and in other words, is the observed test of STAT value consist with this distribution or not. So as long as our result is under the drawn curve, then our result will be usual regarding that it is actually under the observed curve. So another way of judging this would be to ask how many possible test of stat values are more extreme than the one we have observed. And then we can measure this on the sampling distribution curve by calculating the area of the part of the curve, which is as extreme or even more extreme than our observed value. So this area that was more extreme than the value we observed is called the p-value. It indicates the probability of seeing a test of stat as extreme or more extreme than the one we have actually saw. This is will be true if the null hypothesis was actually accurate in this case. And in this case, the p-value is approximately 0.15. Therefore, interpreting this value would be that it is unusual. And unusual is judged in relation to mathematical prediction about whether this data can have been seen if the null hypothesis is true. So, in the conventional methods, and it's important to stress out that this is just an example of the data analysis, the p-value of less than 0.5 is taken to indicate that the observed data are inconsistent with the null hypothesis. While other p-values could be used and sometimes are being used, the conventional methods of using a p-value of 0.05 is regarded as the statistically significant test of stat for the p-value. So for any analyzed data that we have, it must be less than this p-value for it to be regarded as statistically significant. So sometimes the p-value that is less than this point is simply referred to as statistically significant, where some people can say this will reject the null hypothesis. But it is not actually good terminology, but rather we should use the following as the data are inconsistent with the null hypothesis. So in our previous example, how can we decide if team A result is better than that of team B? We should look at the original question, which was, is there a genuine difference in the biomarker level with these two treatments? Then our answer, which should be that we ask the difference between the treatment means, and we have concentrated on the extreme values only in the direction which was A higher than B. So by drawing a measure of the p-value in relation to more extreme values in both of these possibilities, we will assess if our mean value is actually extreme or not. And using the convention of calculating p-value by considering more extreme value in just one direction can give what is called a one-sided or one-tailed p-value. And calculating the p-value by considering a more extreme values in both directions will give us a two-tailed p-value. So whether we use the two-tailed or the one-tailed p-value, the convention of a p-value less than 0.05 is a critical point that is still usually applied in most of the analysis of quantitative data. So if we were using the two-tailed p-value, that is a standard practice unless there are strong scientific arguments to the contrary. So according to the ICH guidelines, it is important to clarify in our analysis chapter in the research, we need to clarify whether we used a one-sided or a two-sided statistical significance that was used. And in particular, to justify the prospective use of a one-sided t-test. So in regard to the p-value, it is not the probability that the null hypothesis is true or the probability that there is no genuine difference, but rather it is defined as the probability that if the null hypothesis is true, then we would see a data of extreme or even more extreme than that we actually saw. So if the sampling process were to be repeated many times, we will still get the same result. And as this process cannot be quite answered in our original question, we will need a by convention to decide that there is no real difference between the observed two groups. So there are two ways that we could be wrong about our analysis of the quick two-group treatments. Then we would decide that the difference is actually real and the null hypothesis is false. This will be regarded as a type 1 error if we are analyzing quantitative samples, or it can be regarded as we decided that there is no substantial evidence to reject the null hypothesis. Then we have committed a type 2 error in the analysis, and therefore our result will not be accurate as appropriate medical research data. And even if we have correctly decided that the stat significant difference is actually real, which doesn't mean that it is actually important. So even if we have observed an effect, it doesn't actually mean that it affects our outcome or our problem that we are seeking to answer. So this can be too small to be real of a clinical value. Therefore, in return, we will have discussed this later. So as a summary of the analysis, we should choose a test of stat or a quantity that measure the effect in which we are interested, which is the function of certain intervention, or even the difference of two means value in the example that we just discussed. Second, we should set up an appropriate null hypothesis. For example, that there is no true difference between the two mean values. Third, we should imagine a process of repeating or repeatedly drawing a sample of data from the population in which the null hypothesis is true. And fourth, we should use a mathematical model to determine the distribution of any possible values of test of stat if the null hypothesis is true. And finally, we should compare the observed value of the test of stat with this distribution to give it a 2B value in general. So we will be taking a break now for Salatul Isha, and then we'll continue discussing the rest of the analysis for quantitative data. Assalamu alaikum wa rahmatullah. Welcome back, everyone. So, as we're discussing the analysis of qualitative data, we'll now continue with the best statistical methods for this type of data analysis. So, the statistical inference, it is defined as the derivation of the conclusion from a given information or premises. So we define a statistical inference to be the derivation of conclusion from the information in the form of data using any statistical method and principles. So one of the most common of these statistical principles is the significant testing. And here we will review some of the most commonly encountered significant testing which are used to make the inference from the sample of data. So the first is the continuous data, which is the t-test. These are used to make inference about mean values in the samples of continuous data. So we can use these tests to make sure that the inference about mean values in a single sample, or to even make inference about many values in differentiation between the mean value in a sample of data from two or more different groups. So t-tests are based on mathematical models that assume the underlying continuous measurement have a normal distribution. And for comparison of data from different groups with the simplest test assumed to have the variance in the two groups that are the same. So in a one sample t-test, it is used in some experimental situations that we may have a set of observation of continuous data that are collected from a single sample of subjects or of observational units. And in such cases, our interest is generally lying in making the inference about the mean value of the population from which these observations were drawn. So we can commonly ask ourselves whether the true mean has a certain pre-specified value or not. So in these types of inference, these can be made using a one sample t-test. So the analysis will depend upon the type of the data that we already have. An example of data, for example, in this case, is a biomarker measurement in a single sample of patients. So if we had 12 samples from a group of patients, we would, for example, observe the following value. And we can test the null hypothesis, that is that the true mean is equal to 10. And we will then derive a two-sided p-values as we have discussed previously. And we will use a simple program written using the R system. So R system and SPSS are the most commonly used program for analyzing medical data. So if we were to enter these data in the R program using the alternative two-sided null hypothesis, we will receive the following value. So it is not a user-friendly package, but it can have appropriate results or meaningful results. So according to the analysis, the p-value is higher than the conventional level of 0.05, and we will interpret this result to mean that these data are consistent with the null hypothesis that the true mean level is equal to 10. Where in the case of a paired t-test usage, in some cases, we have a set of continuous measurements that are recorded before an intervention is applied at baseline, for example, and then at a follow-up measurement on each subject, which is the observational unit that is also made after the intervention. This type is called a paired data. So in this case, we are usually interested in making the inference about the change in the mean from baseline to post-intervention. And we could also quite simply subtract the baseline value from the post-intervention value, or in another way around, and then we would have a single set of difference observations, which we could analyze as a single set of values using the test that was just described. So in this example, we have baseline and post-treatment measurement of biomarker values for a group of 10 subjects. So these subjects were measured at both baseline and post-treatment. And if we were to analyze these data using a paired t-test, which is using our program, if the treatment has no effect, then the true mean value of the difference between the baseline and the post-treatment is 0. And we can test this null hypothesis using the single sample t-test that was described previously. And we will come up with the result that the alternative hypothesis, the true mean, is not equal to 0. So according to this analysis, the p-value is higher than the conventional level of 0.05, and we will interpret it to mean that these data are consistent with the null hypothesis that the true mean difference is equal to 0. So some of the statistical software package will allow an option to perform a paired t-test without the need to calculate the differences between the paired observations. So this can be done in an R program, for example, using the following code, and will give us the same result that these data are consistent with the null hypothesis that the true mean difference is equal 0. An example of this is in a thyroxine level studies in a before and after CST study. We can see the pre-test data and also after 12 months and after 60 months. So in each of these steps, we calculated the mean value, the median, the minimum, and also the maximum value. And these data were compared in an R program and gave the following result in a two-sided or two-tailed p-value. And we interpreted it to mean that the thyroidexin levels post the SCT scans are significantly lower than at the pre-conditioning condition, both at the 12-month follow-up and at the 60-month follow-up period. So in the two-sample t-test usage, it can be used when we have two samples of continuous data, with the samples perhaps from different treatment groups or even from different patient subsets, or just generally from two different conditionings which we want to compare, and we can use the two samples t-test to make conversion of the mean value in the two groups, or equivalently to make inference about the differences between the two mean values. And if there is no genuine difference between the two mean groups and the true difference between the two mean is 0, then the test can be used to assess this null hypothesis. So, as we mentioned, the type of the test will depend upon the type of data that we already have. An example of this is if we had the measurement of biomarker values for two groups, each of 10 subjects with given different drug dosage. So we can use, in this case, a two-sample t-test to compare the mean value and the null hypothesis, that is, the true mean difference is equal to 0. So analyzing these data in R code to perform this simple two-sample t-test as the following by entering these data. So the result that we have is that the p-value is higher than the conventional level of 0.05, and we interpret this to mean that these data are consistent with the null hypothesis, which are that the true mean difference is equal to 0. So to interpret these results, the time to the neutrophils engraftment is 2.1 days, which has a 95% confidence interval, and it is longer for patients who are receiving a graft from an unrelated donor when compared with siblings who have with a sibling donor as the donor for the graft. So in the case of continuous data, we can also use the Wilson rank sum test. As we noted before, the t-test can make a number of assumptions about the data that are being analyzed, and one of which is that the underlying values have a normal distribution. And if we have reason to doubt the validity of this assumption, then we can use the Wilson rank sum test to make the conversion between the two groups of continuous measurement. So this is an example of a non-parametric significant test, such test that can make very general and widely applicable assumptions about the data and are often good alternative to tests that make restrictive assumptions. So an example of this type of data that was used previously, that we have measurement of biomarkers of values for two groups, each of 10 subjects giving different drugs. So we can use a Wilson rank sum test to compare the data distributions and therefore their median values. And if we were to enter these codes in our program, we will have the result that these data are in fact consistent with the null hypothesis that the value is equal to 0. And if we were to implement these results on a gram or a histogram, then we will interpret the mean value with the standard deviation and the median or minimum and maximum values. Another type of data that is needed to be analyzed is the non-parametric test. So if our continuous data is not normally distributed or that standard deviation are very different, then a non-parametric alternative to the t-test, known as the Mann-Whitney test, can be utilized. And another deviation of the same test is called or due to the Wilson rank sum t-test that we just explained. So using the other program for analyzing the data is SPSS. We can use a non-parametric test with two independent samples using the Mann-Whitney test for analysis. So we will only enter the data that we have in these programs and then choose the name of the analysis or the stat test that we want to conduct, and we will immediately have the result. So interpretation of this result can show that there is statistically significant difference in the time to platelet engraftment for patients receiving a graft from an unrelated donor, when compared with a sibling donor that had a median value of 24 days. So If we were to enter the same data in our program and analyze it using the Williamson signed rank test, then similarly, we'll have an unparametric test that can be used to analyze the paired continuous data in a situation in which we don't believe that the assumption of a normally distributed data is true. And we could apply this test or the example of a paired data that we saw previously with the code to perform this test in R. So the result we will get is that the p-value is higher than the conventional level of 0.05. And we will interpret this result to mean that these data are in fact consistent with the null hypothesis, and they are that the true mean difference is equal to 0. So to summarize these type of analysis, we will find that we will need to choose either a paired or a non-paired t-test, depending, of course, on type of the continuous data we have. If they were not paired and normally distributed with similar variance, then we will choose a t-test. And if they were non-paired and not normally distributed with non-similar variance or very small number of subjects, then we will choose the Mann-Whitney test. Where in the case of a paired data and paired t-test or Williamson sign rank test should be used in these cases. While another type of data that we have to analyze is the categorical data. In this type, the qualitative or the categorical data is best presented in the form of a table, such that one variable defines the row and the categories for the other variable will define the column. So the data are arranged in a contingency table, and the individuals are assigned to the appropriate cell of the contingency table according to their value for the two variables. So if we had this type of data in the table, for example, this is a descriptive cross table for the information. We can use a chi-square test for the analysis that is used to test whether there is an association between the row variables and also the column variables. And when the table has only 2 rows or 2 columns, this is then equivalent to the conversion of the proportions. So the chi-square test can compare the observations or the observed number in each of the 4 categories and then compare them with the numbers that are expected if there were no differences between the distribution of patient gender, and also that the greater differences is between the observed and the expected numbers, then this will mean that the larger value of the chi-square test, that is, the less likely it is the difference is due to a chance, but rather to a true effect. So to interpret the result, this will mean that the proportion of sibling to an unrelated donor are different for the sibling in a percentage of 44 to 60, and females of a higher percentage of the patients. So another analysis method is the Fisher exact test. And when the overall total of the table is less than 20, or if it is between 20 and 40, with the smallest of the 4 expected value less than 5, then we can use the Fisher exact test. So as we mentioned, we will use the test depending on the type of the data that we need to analyze. So if we were to enter the same previous data in SPSS program in crosstab statistic, and then choose to analyze it with chi-square test, we will get large tables that generally called Rx tables, and denoting the number of rows to the tables and the column. So the standard chi-square test for a 2 table is generally tested to assess whether the differences are among these proportions or not. But if we were using categories in the columns, we will need a more sensitive test, such as the Fisher square test, which tend to be tested using the chi-square test for trends. So in the table below, the relationship, for example, for the frequency of C-section and the maternal foot size is presented. So this is a proportional example to just a test for the chi-square test. And the standard case in this case is that the value, or it was analyzing using the trend, then the evidence will show a linear trend in the proportion of the women giving birth by their C-section in relation to their shoe size. So this relation is not casual, but can reflect that the shoe size is a conventional indicator for the small pelvic size. Therefore, in summary, categorical data can compare proportions, and in studies where there are two groups and the total number of patients more than 40, then we should use a chi-square test. Also, studies where there are two groups and the total number of patients is less than 40, or if the smallest number is less than 5, then we can use the Fisher exact test. In addition, the studies whether there are more than two groups but not orders, then we can also use chi-square test. And if there are more than two groups which are ordered, we can use either chi-square test, the normal, or the one for trend. So, in summary, there are countless statistical significant tests that are described in the statistical literature, and all of them will produce a p-value, which is a measure of how consistent the data are with the null hypothesis for the test. And most of these statistical significant tests can make some assumptions about the nature of the data, and we will always be sure that we understand what these assumptions are. And we need always to be sure that we understand what the null hypothesis is for the test that is being used. In addition, a low p-value of less than 0.05 can indicate the data that are not consistent with the null hypothesis. And larger p-values more than 0.05 will indicate the data that are consistent with the null hypothesis. So when we use a statistical significant test, we should use it with careful care, as these are not panacea in the medical research, but they can be and are very often overused and used incorrectly or inappropriately. So the misuse and misinterpretation of these statistical significant tests and p-values is very common in the medical literature. So some of the notes that can help with this problem, and also some of the things that are commonly done in significant tests and shouldn't be done with these tests, include the following. First, we shouldn't use multiple significant tests for a certain set of data. And to be cautious about this is to overuse the significant testing. And for this reason, it is important to set out in advance which conversion will be made by the significant test, depending, of course, on the type of the data that we have and that we need to analyze. And according to the ICH guidelines, the statistical sections of the protocol should specify the hypothesis to be tested and the extent to which the primary analysis is planned in a period that will also contribute to the degree of the confidence in the final result. So we shouldn't use statistical significant tests to compare the baseline data. For example, the gender or the age or any other baseline data that we have in our sample. Also, once the data from the clinical trial are available for analysis, it is common practice to carry out tests of baseline homogeneity on the prognostic covariates before proceeding to analyze the effect. And this practice is considerably unsound because there is no practical value in analyzing the percentage of the age, for example. Also, we shouldn't use non-significant test results to claim a non-genuine difference. as these tests is a method to help deciding whether there is a genuine difference between the two treatments or not. And this is often what we want to decide when we are comparing the efficacy measurements. But in some cases, we are really hoping that there is no genuine difference between the two treatments as adverse event on a new drug, for example. Then a statistical significant test, which should give a p-value of more than 0.05, cannot be used to support the claim that there is no genuine difference. So a p-value is only used to test if there is actually a presence of the effect. So a statistical significant test is a method to help decide whether there is genuine effect present or not. And many standard statistical tests can exist which are designed to test a specific effect, such as the difference between the means and the differences between the medians. Also, choosing a significant test that is relevant and appropriate for our data and for our hypothesis we are interested in testing is of paramount from deciding or planning the research. So significant tests can yield a p-value, which will tell us how consistent our data are with the null hypothesis or the data that are showing random results. So thank you for your time. We have reached the end of our webinar for today. If you have questions, please do send them on the chat so we can discuss them. You are welcome. العفو. لو في أسئلة فضلا ارسلوها على الشات عشان نعمل مناقشة. إن شاء الله راح يتم إرسال جميع المحاضرات لكم بعد انتهاء الدورة. الله يعطيكم بالتوفيق. أبشر إن شاء الله. لو في أي مصطلح واجهتوا فيه صعوبة أرسلوه على الشات هنا مباشرة وبشرحه لكم في وقتها. الله يعطيكم العافية. بكرة إن شاء الله من 4 إلى الساعة 9.